triglycerides. So higher the triglycerides, higher is the problem. Is it a bystander or is it a causal relation? So there is this paper from Nature Genetics in 2013 which clearly showed that detailed genetic analysis clearly shows that triglycerides are indeed causally related to coronary artery disease. Again, a very large paper published in the Lancet about 7-8 years back again showed that whichever way you looked, whether based on observational studies or based on genetics, it was clear that triglycerides are associated with increased cardiovascular risk. Now, it is also known, as I was saying, that after you've given high doses of statins, these are the major high-dose statin trials in the primary, in the secondary, and also in the high-risk coronary artery disease settings. If we look at the light blue bars, they are the residual risks. So while the statins lower the mortality and lower the events to the tune of about 30 to 35%, there is a lot of residual risk which is there. And so after the LDL cholesterol, the next guideline directed target is actually non-HDL cholesterol, which essentially means that you subtract the HDL cholesterol from total cholesterol and you get non-HDL cholesterol, which actually consists of the particles which are written in the middle. As regards HDL, a lot has been said, but we know that we've drawn a duck as far as HDL is concerned. And a recent study, a paper, said actually that it is not the amount of HDL, the amount is less important, but the efficiency with which it moves, it gets moved from the arteries, that is perhaps more important, and we'll have to really get to the bottom before we get a successful drug as far as HDL is concerned. This is the triad in diabetes, the dyslipidemic triad in diabetes, and we are aware from the ICMR study in India that triglycerides are the second commonest abnormality. Low HDL in Indians is the commonest abnormality, and therefore, why do we say we should target or lower the triglycerides? Because epidemiological and Mendelian studies clearly show that by virtue of having residual cholesterol, triglycerides are associated with a risk. They are an important cause of the residual risk that stays after we have lowered the LDL cholesterol with the statins. And they are very, very elevated in diabetics, and we all have heard and talked about this fact that India is the diabetic capital of the world. When do we lower it? This is just for the record. 1 millimole of triglycerides is equal to 88.5 milligrams per deciliter of triglycerides, the thing that we are more familiar with. We have both primary and secondary prevention roles, so it has been found to be beneficial both in primary and secondary prevention. The important thing is that the triglyceridemia has to be persistent. That means over a period of 4 to 12 weeks or 3 months after the lifestyle intervention has been done, if the triglycerides are high, they need to be treated. If the fasting triglycerides are more than 150, they are abnormal. If they are more than 440, they say you repeat a fasting sample. This is European Atherosclerosis Society recommendation. We need to be aware that there are certain very rare diseases which cause primary hypertriglyceridemia, but most important or more important are the secondary causes of hypertriglyceridemia, and these are listed here. Largely they would be hovering around diabetes, so obesity, metabolic syndrome, diabetes itself, other thyroid disorders like hypothyroidism, heart failure, renal disease, lupus, a number of drugs that are there, and to top it all, alcoholism. People who consume a lot of alcohol have high triglycerides and they need to watch for it. It has also been seen that the best people who benefit from this intervention is those in whom you've already lowered the LDL cholesterol. So in them, if the triglycerides continue to be high, they have a 32% higher relative risk. So we need to lower these in those patients. How do we do them? I've referred to two references, one from Europe on the top and the 2021 American College of Cardiology statement. Alcohol, in terms of non-pharmacological measures, alcohol abstinence is by far the most important factor. If your patient's triglycerides are extremely high, there should be absolute abstinence, otherwise there should be moderation. Weight loss also leads to lowering of triglycerides, as does physical exercise and the PUFA diet that is advised. This is a rather busy slide, but this actually shows the various drugs that have been used in management of triglycerides. If we look at the P column, the second last column, there are very few which have actually resulted in a statistically significant reduction in events or the composite endpoints while being given on the face of high dose of statins. By and large, the only drug which are presently in clinical use are the omega-3 fatty acids. There is this drug called icosapent-ethyl. This is now available in India. It has been studied in 3 trials given at the bottom. The JELIS trial, which is a Japanese study, the REDUCE-IT trial, which was by Deepak Lal Bhatt, who's an Indian, and it actually showed a 25% reduction in the composite endpoint and including a reduction in the cardiovascular death. There is another study called the EVAPORATE study, which has also shown, which has confirmed the findings of this. However, the placebo used in this study was mineral oil. And there is some debate as to whether it is the bad effects of mineral oil which contributed to the benefit or the beneficial effect of icosapent-ethyl. If your patient has risk of acute pancreatitis because of very high levels, then these are the interventions, including plasmapheresis. These are some of the emerging therapies. Icosapent-ethyl on the top is already there. Some of the drugs are volanersen. This is 2 complex names, but these are the newer pathways and newer things which are being targeted. Evinacumab, which Dr. Hassan also showed, is another drug which is being used to lower the triglycerides. So all in all, we have certain newer drugs which are in the pipeline. We also need to understand that it is a question always asked, can we use the routine fish oil capsules that are available? And this is from the American College of Cardiology statement, clearly shows that non-prescription fish oils, which are used as dietary supplements, do not benefit, and it should be a prescription drug which should be used for management of triglycerides. I cannot, prevent myself from talking about a new drug which has appeared from India. It was the first new clinical chemical entity. It is a dual PPAR agonist, and these dual PPAR agonists basically lower the cholesterol, lower the triglycerides, and they also lower the glucose. Other drugs actually were, when you try to balance their triglyceride lowering and glucose lowering benefits, they created so many side effects that there were increased mortalities. But saroglitazar is an Indian drug. It is an Indian chemical entity which is clinically available now for over 5 to 6 years. It is an extremely beneficial drug shown to reduce the triglycerides by about 40% and also benefits LDL and total cholesterol. So this is the concluding slide from the European Society of Cardiology, which says you define the LDL goal, it stays the primary endpoint. Once you've reached the LDL goal, as was highlighted by Dr. Hassan, if the non-HDL goal is not reached and the triglyceride levels are high, then you treat them for hypertriglyceridemia. If it is very high, then you have to treat it for pancreatitis. So we've discussed the drug options. The major drug option at the present time is icosapent ethyl. I thank you for your kind attention. Thank you very much.
Thank you very much, Sandeep. Can I request my panelists to sort of have their queries answered from Sandeep?
Regarding triglyceride, as you told, there are only few drugs are available. Which is the best drugs we can use?
So that is what I said. The the fibrates which have been used in the past, fenofibrate, etc., they do lower the triglycerides, but they don't reduce the events substantively. They don't reduce the cardiovascular mortality. There are at the present time 2 drugs which are under consideration. Perhaps it is also related to the East-West problems. We are all aware that the Japanese drugs don't do well in the West, so the drugs have to be, promoted from the West, and then they come to the East, they do well. Most of the American drugs do well. So this Indian drug, saroglitazar, has been extremely good. It is in clinical use, and it has had cardiovascular safety. But it is undergoing trials in the US currently for NASH. So that is one drug which is available. The other drug, as I said, is icosapent ethyl, which was used in the REDUCE-IT trial and the EVAPORATE trial. So in both, it has shown that the composite endpoint as well as the cardiovascular mortality is reduced. EVAPORATE actually also did intravascular ultrasound, and they found that the soft plaque part of the atherosclerotic plaque, that is also reduced. So icosapent ethyl is available in India. It is to be given in doses up to 4 grams per day. It is a little costly at present, but as it happens with all the drugs, once there is a competition, the price will come down.
We are using seroquinone also in our daily practice.
Yes.
For 3 to 4 months. If you stop the seroquinone, practice.
Yes. So it has to be like statins. It has to be given lifelong, sir.
Well, that's the time probably we have, Mr. Chairman. If with your permission, can we move on to the next presentation?
Okay, last question, yes, Atul.
What about the krill oil-based omega?
Sir, I showed that emphatically. This is given in 2021 American College of Cardiology statement that the non-prescription oils, which are, in India there are very few. In the places like US, they are absolutely plentiful. Anybody
they are flooding because they are over the counter.
Yes, they are over the counter.
They are not beneficial.
Yeah, they are not beneficial to the heart.
He's saying.
So that has been clearly and categorically said.
Yeah. Okay. Thank you, Sandeep. I think from the being a poor cousin, triglyceride is moving up the ladder.
Yes.
From please, you can please join us here.
Thank you very much, Mr. Chairman. We move on to the last presentation of this session that features Professor Sudeep Kumar from SGBGMS Lucknow to speak on secondary targets for dyslipidemia, choosing between apolipoprotein B versus non-HDL cholesterol for the next 12 minutes or 3 minutes for discussion. Professor Sudeep Kumar, please.
Dr. Sudeep, I'm sure he is here.
Okay, we just have to get him probably. He's in the EC meeting, so I'll just send a word to him so that he can join us. In the meanwhile, probably we could have some discussion so that I'll just hand over to the chairman. Thank you.
Okay, Sandeep, I was just going to ask you.
Sir.
Around 20-30 years back, the large population studies showed a relative risk of triglyceride of 1.2 approximately. Now you think by the later studies that risk factor has moved up, the correlability and the causability?
Sir, the risk factor that has moved up, I showed that if you lower the cholesterol, then you've taken care of the cholesterol risk. So the risk of triglycerides the associative risk of triglycerides kind of goes up. It goes to a value of about 1.32. From 1.2 it goes to 1.32. If you have patients whose cholesterol continues to be high, it is still at around 1.15 approximately. In the same slide that was also shown. That if the cholesterol continues to be high, the relative risk is relatively lower. But if in the population where the cholesterol has already been lowered, the contribution of triglycerides becomes relatively higher.
Yeah, but Sandeep, I mean, even the ESC guidelines and the ACC update, they are mainly focusing on LDL, right from very high risk where they say reduce the LDL to below 50. You can use PCSK9 or anything else. They are still, I would say, hesitant to mention that you also target the triglycerides.
Yes, sir.
So what's your comment on that?
Yes, sure. LDL continues to be the primary target. There's no denying that. But then, as I showed, in all cholesterol trials, the residual risk continues to be high. And you are targeting the components of that residual risk, of which triglyceride is the one which you can actually treat. That's it.
Sandeep,
So,
my one question is that regarding congestion, have you any data where LDL is desirable, but only TG is high? Isolated hypertriglyceridemia,
sir,
where LDL are within normal limits.
yes, sir.
Are they related with the congestion? LDL is normal.
Yes, sir.
Or let us
That's,
say expected limit is there, only high TG.
sir, in diabetics, you can have absolutely normal LDL cholesterol levels and fairly high triglyceride levels. Almost 1 in 3 people who are diabetics have high triglycerides, whereas LDL cholesterol is high in less than 10%. So we do have a population where
What about non-diabetics?
sorry, say that?
Diabetes is known to have high TG.
Yes,
High TG is a part of, you have
Yes.
to select out
In-
that
in-
uncontrolled diabetes,
Yes.
uncontrolled hypothyroidism,
Yes.
or alcohol consumption is more. But I am asking, if LDL is near normal
yes.
and he is a non-diabetic,
Yes.
only high TG is there. So
I-
is it still related to
I
causal-
would not say, sir, that I'm aware of any sub-analysis, but there are large population-based studies. I showed you a study from Copenhagen City, which is a long-term study spread over several decades, and 100,000 patient, 99,000 something patient study. So I'm sure there would be a percentage of people who have normal cholesterol in that.
and high TG only.
And high TG only, because TG they have considered. They have not considered the
But
LDL
so far
cholesterol.
there has been a lot of confusion regarding high TG.
Sure, there has been.
Whether to treat it or not,
So-
that is otherwise in recommendations, you
that-
handle LDL. Once you have handled LDL to desirable level, then you look for SDL or high TG.
Exactly.
And then you try to correct both of them also.
Yes, sir.
But
HDL
you have to,
cannot.
first target is still continues without any discussion that LDL target is the first source.
I've said that in so many words, sir.
Actually,
LDL continues to be the
looking
main
at it
target.
from another
But
way,
high TG is now
all-
coming as a recognition.
Yes.
you're right, but looking at it from another way, all the risk scores which have been developed, I don't think they are giving triglyceride any prominence there.
Not.
Now they are restudying it to see the role of triglycerides. We don't yet have the answers, so we don't know.
Sir,
Ramesh, you were saying something.
That is also because of the fact, sir, that the major studies, population-based studies on triglycerides have come in 2012, 2013, as late as that, less than 10 years ago. So the things are still evolving. The cholesterol guidelines haven't evolved immediately. They've evolved over several years, in fact decades. So,
Can I make a comment, sir? The type of coronary disease which we are in the habit of managing in our day-to-day practice is basically 3 types. One is identifiable coronary lesions which are identified on the epicardial coronary vessels. The another subset is MINOCA and the third subset is microvascular disease. So I would like to know the opinion of the House regarding lipid management in people who have got either MINOCA or microvascular phenomena presenting as florid angina. Is there any sort of consensus regarding the lipid management in Minoca category or microvascular?
Very controversial
Personally-
question.
Yeah, personally, I would say that these are to be treated as intermediate risk, and you should treat them, treat the LDL, but not so aggressively as you would like to treat it and
In a
establish
ACS
MI.
patient.
That's my practical viewpoint. I'm not sure you maybe have some more.
What you are
points.
saying is correct to the extent once the levels are abnormal, then obviously they should be targeted.
Yep.
But once the levels are beautifully within normal range in these two subsets, I don't think there is any concept or there is any logic to aggressively treat them or bring it down.
See, Minoca basically is an angiographic diagnosis.
Exactly.
We can't deny that you may be having some plaques.
Exactly.
So low dose statins can help you by their pleiotropic effects. But that's about all. You are not targeting the LDL there because you have...
Dr. Rajiv has a point, sir.
Thank you.
Thank you. I'm sorry for interruption. But I'll say, practically speaking, no patient who has expressed disease has got a normal lipid profile. That is a very wrong statement. So if you have a LDL of 100 and an expressed atheroma on coronary angio, it is as bad as anything else. It is a secondary prevention. Minoca is non-obstructive, but atherosclerosis is same. So there is no dilution in goals. They have to be aggressively chased. Today's Minoca will become obstructive disease tomorrow. So in my perception, and as far as I understand, there is nothing like less aggressive statin approach. Once you have expressed atherosclerosis, it is atherosclerosis. The LDL level, whatever they are high for the individual, and you have to go by 50% reduction in LDL. That is what I'm saying. So if you have a LDL of 80 with Minoca, he has to be 40. It's as simple as that.
Okay.
Dr. Vikas.
Yeah, sir, coming back to triglyceride,
I would like to, sir,
Yeah.
would you permit me?
Sir, regarding diabetic dyslipidemia, the most common abnormality that we commonly encounter is low HDL and high triglycerides. Regarding the drug therapy that you talked about, would be your own preference if somebody with high triglycerides comes over? We have saroglitazar, we have icosapentile, ethyl, but looking at the data that we have, would you prefer any drug? Because icosapentile, it's a large dose of icosapentile that we can. How is the tolerability of the drug? Saroglitazar, I think, is a more tolerable drug to the patient till the data we have right now.
Yes, I would agree on that because icosapent ethyl in India has been available only for last few months actually. The penetration is extremely poor and
it's costly.
It is costly. They are still finding their feet. So saroglitazar is a fairly good option. It certainly lowers the triglycerides. Over a period of time, they have data of close to 35 to 40,000 patients, which says that there are no adverse cardiovascular events. So the it may not be lowering the mortality, but it is at least cardio safe. That is the thing.
So I think the buzzer has been given by Mr. Padmanabhan. Dr. Bansal, your one-line comment.
One line. I would like to say that triglyceride more than 500 and LDL more than 100 is to be treated. Otherwise, no drug is needed. Only lifestyle modification.
Sir, I would say that's your personal opinion, but anyway, thank you very much.
Thank you very much, Mr. Chairman. We'd like to thank the members of the chairperson and the expert panel and our speakers for making this an enlightening session. Ladies and gentlemen, that was a session on lipidology.